Now we are going to start liver. So in liver, first we are going to discuss the anatomy. Question: what is the normal weight of liver? So in males the normal weight of liver is 1800 grams and in females it is 1400 grams. So the weight of liver in males it is 1800 grams and in females it is 1400 grams. What is the glycogen storage capacity? And the glycogen storage capacity is 65 grams per kg of liver tissue. So next question is glycogen storage capacity, and this is 65 grams per kg of liver tissue. So 65 grams per kg of liver tissue, right? You must be knowing that there are two organs in the body which are having dual blood supply. One is liver and one is lungs. So liver and lungs are having dual blood supply. Okay, so what is the blood supply of liver? You must be knowing that in liver the 75% blood supply comes from portal vein and 25% from hepatic artery, right? So in liver there is dual blood supply, important property, dual blood supply. And the second important property, that liver is the only organ in the body which is having property of regeneration. So liver is having property of regeneration. Clear? So we discussed that dual blood supply. In dual blood supply, this 75% blood supply comes from portal vein. So portal vein and hepatic artery. Clear? 75% blood supply from portal vein, 25% from hepatic artery. So 75% and 25%, right? Now in portal vein the blood is mainly deoxygenated, right? So despite of 75% blood supply by portal vein, it is going to supply only 50 to 70% of oxygen. But in hepatic artery, since it contains oxygenated blood, so it is going to supply 30 to 50% of oxygen. So next question is, how much oxygen supply from portal vein? 50 to 70%. And how much oxygen supply from hepatic artery? It's 30 to 50%. Another very important property, see, HCC, hepatocellular carcinoma, is exclusively supplied by branches of hepatic artery. So very important property, hepatocellular carcinoma, this is exclusively supplied by branches of hepatic artery. Clear? Now what is the application of this fact? Yes, the application of this particular fact is in the radiology. If we are going to perform the triple phase CT in radiology, the investigation of choice for diagnosis of HCC, it is triple phase CT. Triple phase CT. And what is the diagnostic criteria on triple phase CT? It is the arterial hypervascularization with venous washout. So the diagnostic criteria is arterial hypervascularization, arterial hypervascularization with venous washout. Venous washout. Okay. Now what is the simple concept behind this? Why it is known as triple phase CT? You must have seen how CT is being done. So without giving contrast, if you take the section, that is known as non-contrast CT. And if you give contrast and then you take the cut section, that is known as contrast enhanced CT. Clear? So suppose I am taking a patient of HCC for CCT abdomen, right? Before giving contrast, if I am taking the section, that is known as non-contrast CT. So this phase is known as non-contrast phase. Clear? Now you gave contrast, injected, so you are going to inject the contrast. Now see, IV the contrast is being given, so here the contrast is going via veins. Finally it is reaching where? Superior vena cava. Via superior vena cava it reaches right atrium, right ventricle, then lungs, then left atrium and left ventricle. From the left ventricle, contrast is pumped into arterial circulation, and after going into arterial circulation, it is going into venous circulation. This is the sequence. Now, hepatocellular carcinoma is exclusively supplied by branches of hepatic artery. So in arterial phase, if I'm going to take the section, what the HCC will appear whiter, it will be more white, right? And if you're going to take the cut section in venous phase, what there is washout of contrast. So how many phases? 3. First we took section in non-contrast phase, then arterial phase, and then venous phase. So triple phase CT means 3 phases. What are those? Non-contrast phase, then there is arterial phase, and third is venous phase. Clear? So this is triple phase CT. Okay, so there will be arterial hypervascularization with venous washout. How it looks like? So here you can see this is the arterial phase, and here you can see there is arterial hypervascularization, and here see there is washout of contrast. So this is the venous phase in which there is washout of the contrast. So arterial hypervascularization with venous washout, and this is the diagnostic radiological criteria for hepatocellular carcinoma. Now have a look of this picture. What is this? It looks like Mickey Mouse, but actually what is this? This is the relationship of portal triad which appears on ultrasound. So whenever we are going to perform the ultrasound, the portal triad looks like Mickey Mouse, and that's why what is the name of this view? This view is known as Mickey Mouse view. So what is the name of this view? This is Mickey Mouse view. Clear? So portal triad on ultrasound looks like Mickey Mouse. So this is known as Mickey Mouse view. Now see, this is portal vein, this is bile duct, and this is hepatic artery. Clear? So you can crack the question of anatomy also by this relation, that which structure is posterior, obviously portal vein, which structure is on right side or lateral, this is bile duct, and which structure is on left side or medial, that is hepatic artery. So this is posterior, this is on right side or lateral, and this is on left side or medial. Clear? See, previously the liver was divided into 2 lobes by one external landmark by both anatomist and surgeon. And what was that external landmark? This external landmark was falciform ligament. So liver was divided wrongly into 2 halves on the basis of one external landmark, that's falciform ligament. Later, Conneaut divided liver into 8 segments on the basis of 2 structures, and that is portal vein and hepatic vein. There is a question, before discussing the anatomical division, let's discuss the physiological division. So this question was asked in NEET recently, that what is the name of physiological line of demarcation between right and left lobe? So the question, physiological line of demarcation between right lobe and left lobe. And this physiological line of demarcation is known as cholecystocvena-caval line, also known as cholecystoccaval line. So what is this cholecystoccaval or cholecystovena-caval line? It's the physiological, be careful, physiological line of demarcation between right and left lobe. Now we are going to discuss in detail the Conneaut liver segments. So we discussed Conneaut divided liver into 8 segments. 8 segments on the basis of 2 structures. And what are those 2 structures? Yes, it's the portal vein and hepatic vein, right? So generally in majority of questions both options are given, but if you see the AIIMS paper, in AIIMS paper both options were mentioned, not together, separately. So out of portal vein and hepatic vein, if we had to choose one option, it's mainly because of portal vein, right? So Conneaut divided liver into 8 segments on the basis of 2 structures, portal vein and hepatic vein. Mainly it's because of portal vein. Now see the anatomy. This is inferior vena cava. Clear? And this is gallbladder fossa. There is a line which passes from left side of inferior vena cava and goes till gallbladder fossa. What is the name of this line? You must be knowing. The name of this line is Cantley's line. So this is Cantley's line. It is also known as main portal fissure. So it is also known as main portal fissure. Similarly, in the left lobe, there is left portal fissure, and in the right lobe, there is right portal fissure. Right portal fissure. Clear? So we discussed that two structures on the basis of which we are going to divide the segments of liver, that is portal vein and hepatic vein. And how many hepatic veins are there? There is middle hepatic vein, there is right hepatic vein, and there is left hepatic vein. So one question is asked, from main portal fissure, from this main portal fissure or via this main portal fissure, which vein will pass? It's the middle hepatic vein. Via left portal fissure, which hepatic vein pass? Yes, left hepatic vein. And via right portal fissure, which hepatic vein will pass? Yes, it is the right hepatic vein. Got it? Now see the distribution of the segments. So here, this is segment 2, this is segment 3, this is segment 4A, this is 4B, this is 5, this is 6, this is 7, and this is 8. You cannot see segment 1 from anterior direction. Why? Because the location of segment 1 is posterior inferior. So segment 1 is not visualized from anterior direction. Clear? This is the segmental distribution. And if you can see carefully, here you can see that gallbladder is in relation to two segments of liver. So what are those two segments of liver which are closely related to gallbladder? That is 4B and 5. Now see, what is the application of this statement? Question is asked that if there is carcinoma gallbladder, so in carcinoma gallbladder, which two segments of liver are involved at early stage? 4B and 5. So extended cholecystectomy performed for carcinoma gallbladder. In that extended cholecystectomy, which two segments are routinely removed? 4B and 5. So first question related to gallbladder is in relation to two segments of liver, and that's 4B and 5. These two segments are involved at early stage. Involved at early stage. Clear? And removed in extended cholecystectomy. These are removed routinely in extended cholecystectomy. Clear? 3 questions related to this basic fact. Now see the diagrammatic representation again. So here you can see that in left lobe of liver, which segments are included? So in left lobe of liver, the segments which are included are 2, 3, 4. 4 means 4A, 4B. And in right lobe of liver, which segments are included? In right lobe, it's the 5, 6, 7, 8. Segment 1 is considered a separate lobe. Right? Now see, in the right lobe, there are two sectors. One is right anterior sector and one is right posterior sector. So what are the segments which are included in this right anterior sector? So if you see this right anterior sector, the segments included are 5 and 8. Similarly, in right posterior sector, what are the segments included? It is 6 and 7. So right anterior sector contains segment 5 and 8. Right posterior sector contains segment 6 and 7. If we see this left anterior sector, this left anterior sector contains segment 3 and 4. 4 means 4A, 4B. And you see the left posterior sector is the only sector which contains single segment. Clear? So see the important points. So here you can see in the right lobe, what are the segments included? It is 5, 6, 7 and 8. Clear? In right lobe, there is right anterior sector, and this right anterior sector contains 5 and 8, 5 and 8, and there is right posterior sector, right posterior sector contains 6 and 7, 6 and 7. Similarly, in the left lobe, what are the segments included? The segments are 2, 3 and 4. And in left anterior sector, what are the segments included? We discussed, and that is 3 and 4. And what about the left posterior sector. This is frequently asked in exam, that left posterior sector is the only sector which contains single segment, and which segment it contains? Segment 2. This is frequently asked. Left posterior sector is the only sector which contains a single segment, that is segment 2, right? Now one simple question is asked, if right lobe contains segment 5, 6, 7, 8, so if I am going to perform right hemihepatectomy, what are the segments removed? It is 5, 6, 7, 8. If left lobe contains segment 2, 3, 4 and I am going to perform left hemihepatectomy, so what are the segments which are removed? 2, 3, 4, right? So if in surgery 5, 6, 7, 8 is removed, this is right hemihepatectomy. 2, 3, 4 is removed, this is left hemihepatectomy. So it is easy to understand the hemihepatectomy, but the question is asked, what is extended hepatectomy? The other name of extended hepatectomy is also known as trisegmentectomy. See, the term trisegmentectomy appears like, in this procedure we are going to remove 3 segments, but it is actually misnomer. The name is trisegmentectomy, but we are going to remove 3 sectors, right? So here in the picture you can see that this is the right hemihepatectomy, this is the left hemihepatectomy, this is the left hemihepatectomy. So in right hemihepatectomy we are going to remove segment 5 to segment 8. In left hemihepatectomy we are going to remove segment 2 to segment 4. Now what is trisegmentectomy? Trisegmentectomy is also known as extended hepatectomy. This is also known as extended hepatectomy. So if we are going to discuss right trisegmentectomy, the name should be extended right hepatectomy, and if it is left trisegmentectomy, it means it is extended left hepatectomy. Okay, so suppose the question is asked, in right trisegmentectomy, what are the segments of liver which are removed? So here you can see, apart from 4, 5, 6, 7, 8, I am going to remove what? Additional what? 4A and 4B. So right trisegmentectomy is also known as extended right hepatectomy, and in this extended right hepatectomy I am going to remove segment 5 to segment 8 plus 4A and 4B. Simple. Now let's discuss left trisegmentectomy. Left trisegmentectomy. So obviously what should be the name? It is also known as extended left hepatectomy. Extended left hepatectomy. Clear? And you can see here what I'm going to remove. Apart from segment 2, 3, 4, I'm going to remove the 5 and 8. 5 and 8. So here there is removal of segment 2 to 4, 2, 3, 4 plus 5 and 8. Clear? So these are the questions which are asked frequently in the exam. After that, 2 named segments are asked in exam. What is the name of segment 1? Segment 1 is known as caudate lobe. And what is the name of segment 4? Segment 4 is known as quadrate lobe. So the name of segment 1, it is known as caudate lobe. And segment 4, this is known as quadrate lobe. Quadrate lobe. Clear? If you have seen the papers, most frequently asked segment in the liver is segment 1, that is caudate lobe. Why? Because of its unique properties. We discussed previously that we don't include segment 1 firmly. We discussed previously that we don't include segment 1 in left or right lobe. It is considered as a separate lobe because of certain unique properties. Clear? So what are those unique properties? What are the parts? What is its relation? So here you can see the shape. It is L-shaped structure and it is in relation to inferior vena cava. The first question which is asked frequently is, what are the parts of caudate lobe? So this is caudate lobe. There are 3 parts. This is known as spigal lobe. This part around vena cava, this is paracaval portion. Paracaval portion. Okay. And this is caudate process. Caudate process. Right? So what are the three parts? Pygial lobe, paracaval portion, caudate process. In AIIMS previously one question was asked, what? That which part of caudate lobe is considered as segment 1 and which part of caudate lobe is considered as segment 9. So see, this pygial lobe, it is considered as segment 1 and this paracaval portion, it is considered as segment 9. So what are the unique properties of caudate lobe? First, see the blood supply. Blood supply of caudate lobe. It receives blood supply from both right as well as left branch of portal vein. So blood supply is from both left and right branch of portal vein. Clear? Out of left and right branch, mainly it is receiving its blood supply from which branch? Mainly from left branch. Similarly, see the biliary drainage. Biliary drainage. The biliary drainage also goes to left hepatic duct and right hepatic duct. So it goes to left hepatic duct and right hepatic duct. Again, mainly to which hepatic duct? So mainly it goes to left hepatic duct. But the venous drainage of caudate lobe goes directly into inferior vena cava via 6 to 10 branches. So here you can see the venous drainage goes directly into IVC via 6 to 10 branches. So the venous drainage, it goes directly to inferior vena cava. Now see, because of these unique properties, there are certain advantages and certain disadvantages. Now see the first advantage. You must be knowing Budd-Chiari syndrome. What happens in Budd-Chiari syndrome? Budd-Chiari syndrome is characterized by hepatic venous outflow obstruction, and it can be because of hepatic vein thrombosis or IVC obstruction. Mainly, Budd-Chiari syndrome is caused by hepatic vein thrombosis. Clear? Now, whenever there is hepatic vein thrombosis, there is hepatic venous outflow obstruction. So, almost whole liver is affected. And if there is arterial supply but obstructed venous drainage, so what happens to the liver? Liver is congested. Over a period of time, what will happen to the liver? Yes, there is necrosis, and after that, the liver will be atrophied. But what is the exception? If Budd-Chiari syndrome is caused by hepatic vein thrombosis, whole liver is affected, but one segment is spared. Which one? Caudate lobe. Why? Because it is not being drained by hepatic vein. Its venous drainage goes directly into IVC. So, in Budd-Chiari syndrome caused by hepatic vein thrombosis, which segment is spared? Caudate lobe. This caudate lobe is spared. And what will happen? Over a period of time, the whole liver is atrophied. But what will happen to caudate lobe? It is hypertrophied. So over a period of time, rest of the liver segments are atrophied. So there is liver atrophy, but there is caudate lobe hypertrophy. So there is caudate lobe hypertrophy. And this hypertrophy of caudate lobe on scintigraphy appears as central hotspot sign. So because of this hypertrophy on scintigraphy, there is a sign. Which one? There is central hotspot sign. Central hotspot sign. Simple. Now see what is the disadvantage. We discussed that the biliary drainage of caudate lobe goes to left hepatic duct also, right hepatic duct also, mainly to the left hepatic duct. So if you see the diagram, this is the liver, this is the bile duct, this is the gallbladder. Clear? Now see, this is the L-shaped structure, what? Caudate lobe. Its biliary drainage is going to the right hepatic duct as well as to the left hepatic duct. And you must be knowing what is the most common site of cholangiocarcinoma, malignant tumor of bile duct, cholangiocarcinoma, and the most common site of cholangiocarcinoma is what? Hilum. So any patient who is having this hilar cholangiocarcinoma, Yes, or the cholangiocarcinoma arising from left hepatic duct or right hepatic duct. What's the problem? In these situations, there is early involvement of which segment of liver? Segment 1. So there is involvement of caudate lobe. So there is early involvement of caudate lobe in hilar cholangiocarcinoma. And because of this, in patients of hilar cholangiocarcinoma, we go for routine caudate lobectomy. So what's the disadvantage? In hilar cholangiocarcinoma, there is early involvement of caudate lobe, and that's why we go for routine caudate lobectomy. Routine caudate lobectomy. Now see the relation of portal vein, bile duct and hepatic artery means portal triad again. So we discussed this is portal vein, this is bile duct, and this is hepatic artery. So this is Mickey Mouse view. So this is the relation, this is portal vein, this is bile duct, this is hepatic artery. So what is the location of this portal triad? This portal triad is located in the free edge of hepatoduodenal ligament. Hepatoduodenal ligament means ligament between hepato means liver, duodenal means duodenum. So in the free edge of hepatoduodenal ligament, this portal triad is located. You must be knowing that there is a foramen of Winslow. Via foramen of Winslow, there is communication between lesser sac and greater sac. So what? If I'm inserting my finger into foramen of Winslow, yes, and I'm guiding a clamp in the foramen of Winslow, and if I'm going to apply this clamp, what will happen? Yes, the inflow of liver is occluded. Why? Because 75% blood is coming from portal vein and 25% from hepatic artery. So if you apply a clamp, yes, in foramen of Winslow, this is known as Pringle's maneuver, and the other name of this Pringle's maneuver is total inflow occlusion, because you occluded the blood supply of the liver. So what's the name of this maneuver? Pringle's maneuver, one of the frequently asked topic in AIIMS and NEET. So Pringle's maneuver. What is the other name of this Pringle's maneuver? This is also known as total inflow occlusion. Total inflow occlusion. So in this case, what we place? Placement of clamp in foramen of Winslow. Placement of clamp in foramen of Winslow. So see the diagrammatic representation. Now see the diagrammatic representation. Here you can see that this is the foramen of Winslow via which lesser sac and greater sac communicates. Okay, you applied this clamp here. Okay, and when you applied the clamp, you're going to obstruct all these three structures: portal vein, hepatic artery, and bile duct. So question comes that by Pringle's maneuver, bleeding is controlled from which two structures? So by Pringle's maneuver controls bleeding of obviously portal vein and hepatic artery. This question was asked in NEET, that out of portal vein and hepatic artery, bleeding is effectively controlled from which structure? Yes, so if you see, the pressure is lesser in the portal vein and it is very easy to occlude portal vein as compared to hepatic artery. So because of low pressure, the bleeding is effectively controlled. Portal vein bleeding is effectively controlled as compared to hepatic artery. Second important point, bleeding is not controlled from IVC and hepatic vein. Why? Because these structures are not occluded in Pringle's maneuver. So another important point, it doesn't control Pringle's maneuver, doesn't control bleeding. It doesn't control bleeding from inferior vena cava and hepatic vein. So these are important points related to Pringle's maneuver. Now we are going to discuss pyogenic liver abscess. Pyogenic liver abscess. Okay, is the most common type of liver abscess, right? And liver is the most common solid organ. Liver is the most common solid organ involved by abscess. You must have seen a case of liver abscess because it's very common. Generally, this pyogenic liver abscess, it is more common in alcoholic males and it is usually seen in 5th to 6th decade. So, it is seen in 5th to 6th decade and it is more common in alcoholic males. Clear? Now, the term is pyogenic. Okay, so it means there is pus collection and it is caused by pus forming organism, and that is bacteria. So question is asked, what is the most common organism responsible for pyogenic liver abscess? If we are talking about most common organism worldwide, it is E. coli, and in Asian population it is Klebsiella. So question is asked that what is the most common organism responsible for pyogenic liver abscess worldwide? The most common organism responsible for pyogenic liver abscess worldwide is E. coli, in Asian population is Klebsiella, and in children suffering from chronic granulomatous disease it is Staph aureus. So see the organisms, most common organism responsible for pyogenic liver abscess worldwide, it is E. coli. In Asian population it is Klebsiella, and in children suffering from chronic granulomatous disease, right? And that's Staph aureus. This is Staph aureus. Okay, so see, what are the various routes of infection in pyogenic liver abscess? We discussed that this is portal triad, this is portal vein, bile duct and hepatic artery. So whatever the infections which are going to the liver, those infections are mainly going via these three routes, either via bile duct or portal vein or hepatic artery. So question is asked, out of these three routes which one is most common, and it's the bile duct or biliary tract. So routes of infection, what are the routes of infection? The most common route is bile duct or biliary tract. Right? Now see how the infection reaches liver and what are the predisposing conditions. So you can see this is the liver, this is the bile duct, right? It is the cholangitis which is leading to pyogenic liver abscess. And what is the factor responsible for cholangitis? There are two factors which are mandatory. One is obstruction and one is infection. So generally there is cholangitis. And what is the most common cause of cholangitis? It's the CBD stone. And another cause is cholangiocarcinoma, generally in Western countries. Now see what's the problem here. There is obstruction because of CBD stone or cholangiocarcinoma, and there is infection. So whenever there is cholangitis, what will happen? This infection reaches liver. So this infection reaches liver. So biliary tract is the most common route for pyogenic liver abscess. The second most common route is portal vein. Is the portal vein. Now see how this portal vein is formed. This is the liver. Clear? This is the inferior mesenteric vein. This is splenic vein. This is superior mesenteric vein. This is portal vein. Clear? Inferior mesenteric vein, there is splenic vein, superior mesenteric vein and portal vein, right? Now see, if some patient is having acute appendicitis, right, and there is delay in diagnosis. So if there is delay in diagnosis in the patient of acute appendicitis and there is appendicular perforation, what will happen? See here, this is cecum, this is appendix. So whenever there is appendicular perforation, you can see what? The organism via superior mesenteric vein reaches portal vein and then it can reach the liver. So in cases of appendicular perforation, what happens? The infection can reach to the liver via portal vein. Second, suppose the patient is having what? Diverticulitis. And you know that the most common site of colonic diverticulitis is sigmoid colon. So if there is diverticulitis, what is the problem here? The organism can reach inferior mesenteric vein, then splenic vein, then portal vein, and then liver. Clear? So in cases of diverticulitis also, what? The organism can reach the liver and it can cause what? The liver abscess. So in portal vein, this is the second most common route, and appendicular perforation or diverticulitis increases the risk. Diverticulitis increases the risk. The third route is hepatic artery. Hepatic artery. Now this route is important in children. The children who are suffering from chronic granulomatous disease. Now what is the problem in chronic granulomatous disease? There is defective neutrophil function, and because of this defective neutrophil function there is increased risk of subacute bacterial endocarditis. You must be knowing that this subacute bacterial endocarditis is mainly caused by Staph aureus and Streptococcus. So the patients who are having chronic granulomatous disease, there is increased risk of pyogenic liver abscess. Infection reaches the liver via hepatic artery, and the most common organism responsible, Staph aureus. Okay, so this is important in children suffering from chronic granulomatous disease, and in patients with chronic granulomatous disease there is defective neutrophil function, so there is increased risk of subacute bacterial endocarditis, and because of this via hepatic artery the infection reaches the liver leading to pyogenic liver abscess. So these are the three routes, and the fourth is there can be direct extension of infection. Direct extension of infection. So how this direct extension of infection to the liver can occur? See the diagram. This is the dome of diaphragm. This is the liver. This is the gallbladder. This is the bile duct. This is the kidney. See, if this patient is having pus collection in thoracic cavity, that is known as pyothorax. Clear? So if there is pyothorax, what? This infection can reach the liver. So first, there is direct extension of infection from pyothorax. See the second situation. Sometimes there is collection of pus just below diaphragm, and the name of this condition is subdiaphragmatic abscess. So see, here is the pus collection. So this is subdiaphragmatic abscess, and even this can extend to the liver. So subdiaphragmatic abscess. Now see the third condition. There is acute suppurative cholecystitis. In acute suppurative cholecystitis, there is pus collection around gallbladder. In this case also, you can see there is direct extension. So this is acute suppurative cholecystitis. Clear? And some part of kidney is in indirect relation with liver. So whenever there is pus collection around kidney, and this is known as perinephric abscess. So the patients who are having perinephric abscess, even in these cases, what? There can be direct extension to the liver. So what? Perinephric abscess. Right? So there can be direct extension of infection from these four conditions. Now see how this liver abscess looks like. This is the liver, and in the liver there is pus filled cavity. Clear? So here you can see that this is the pus collection. Now there are certain important points related to pus collection anywhere in the body, and this we will keep on repeating in the whole surgery subject. Suppose anywhere in the body there is pus collection. So what will happen? At the site of pus collection there is pain and there is tenderness. There is fever with chills and rigor. And how we are going to manage? If the pus collection is there, it has to be drained. If it is superficial pus collection, it is drained by incision and drainage, and we have to give antibiotics. If it is deeply located inside abdomen or somewhere else, we have to go for ultrasound or CT guided percutaneous aspiration, and we give antibiotics. Clear? So in the liver there is pus collection, right? And because of this pus collection, what is the most common symptom? There is fever with chills and rigor. There is pus collection. Because of this, what happens? There is abdominal pain. Second important point, there is a most characteristic symptom in any kind of liver disorder. And what is that most characteristic symptom in any kind of liver disorder? And that is what? Fatigue. Clear? With fatigue in liver disorders, there is anorexia also. So you will notice that in majority of liver disorders, generally anorexia and fatigue, these two symptoms are complementary. Clear? So here we are going to discuss the clinical features. So in cases of pyogenic liver abscess, what is the most common symptom? The most common symptom is fever with chills and rigor. It's the fever with chills and rigor. What are the other symptoms? The other symptoms are abdominal pain, and we discussed there is anorexia and fatigue. Anorexia and fatigue. Question: what is the most characteristic symptom? Most characteristic symptom of liver disease, and the most characteristic symptom is fatigue. In PGI Chandigarh, this question was asked that in which type of liver abscess jaundice is more common. It is common in amoebic liver abscess or pyogenic liver abscess. So if you see this diagram, we discussed that the most common route for pyogenic liver abscess is what? The biliary tract. And the most common cause is cholangitis. What is the most common cause of cholangitis? Yes, it is the choledocholithiasis or CBD stone. And because of this CBD stone, there is obstruction and that can lead to jaundice. That's why in patients of pyogenic liver abscess, in 20 to 25% patients, you will find what? Jaundice. And the second indirect question, if there is CBD obstruction, what is the most common LFT abnormality seen in patients of pyogenic liver abscess? Obviously, it is, yes, raised ALP. So two questions here. Because of this obstruction, in 20 to 25% patients, there is jaundice. There is jaundice, and the most common LFT abnormality. The most common LFT abnormality is raised ALP, raised alkaline phosphatase, right? Generally, these patients are brought to our emergency, sometimes OPD. And whenever these patients are brought to our emergency, the question is asked, what is the first investigation done? So the first investigation done in a suspected case of hepatobiliary pancreatic disease, you have seen in emergency what we ask the relative, that yes, take this patient for ultrasound. So the first investigation done in a suspected case of hepatobiliary pancreatic disease, and that is ultrasound. Now see, on ultrasound also you can make the diagnosis. So diagnosis is highly suggested by ultrasound and CT. And whenever we are sending this patient, we send our intern and PG also, postgraduate student also, and he is going to perform the aspiration. When the radiologist is performing ultrasound and he thinks that most probably this is what? Pyogenic liver abscess. So he insert a needle and aspirate. On aspiration, if there is pus collection, what diagnosis is confirmed? For organism, we send this pus for culture sensitivity, right? So see the questions which are asked related to investigations. The questions related to investigations. First, what is the first investigation done in suspected case of hepatobiliary pancreatic disease? And that is ultrasound. Clear? Second, diagnosis is highly suggested by. Diagnosis is highly suggested by ultrasound or CT. But the question, diagnosis is confirmed by or investigation of choice for diagnosis, it's aspiration and culture. So diagnosis is confirmed by, it's confirmed by indirectly investigation of choice for diagnosis. Okay, so this is what? Aspiration and culture. Aspiration and culture. Clear? If there is pus collection, it has to be drained. So how we are going to drain it? See, this is the liver, this is the pus collection. So what we do, we insert a pictal catheter and attach it with a urobag. Clear? So what will happen? The pus collection keeps coming out in this urobag. Now see, I told you it is percutaneous catheter drainage. It is not percutaneous aspiration. It is percutaneous catheter drainage, which is the treatment of choice. Why? Because whenever we are going to insert the catheter, whole cavity is not liquefied, so it takes time for liquefaction. So what is the treatment of choice? It is percutaneous catheter drainage with systemic antibiotics. So percutaneous catheter drainage with systemic antibiotics. Next is amoebic liver abscess. Amoebic liver abscess. So what is the organism responsible for amoebic liver abscess? It is Entamoeba histolytica. So the organism responsible is Entamoeba histolytica. Clear? So if we compare pyogenic liver abscess with amoebic liver abscess, we discussed that in pyogenic liver abscess it is more common in alcoholic males, age group 5th to 6th decade. But if you are talking about this amoebic liver abscess, it is more common in developing countries and the patients are relatively young as compared to pyogenic liver abscess. So here it is more common in developing countries. Clear? And here the patients are young. So why it is more common in developing countries? One of the basic difference between developing countries and developed countries is what? Poor sanitation barrier, right? And because of this poor sanitation barrier, what happens? There is frequent mixing of fecal matter with food or water, right? And especially the places where mass food preparation is going on. Clear? So what is the most common route of infection? It's the fecal-oral. And what is the infective stage? It's the quadrinucleate cyst. So most common route of infection, this is fecal-oral. What is the infective stage? And this is quadrinucleate cyst. Quadrinucleate cyst. Okay. Now see the problem. Whenever there is accidental ingestion because of this fecal-oral route of transmission, the patient is going to ingest this quadrinucleate cyst. This quadrinucleate cyst undergoes a further division, and after that what will happen? This quadrinucleate cyst converts into octanucleate cyst, right? And because of this octanucleate cyst, 8 trophozoites are released. Clear? So 8 trophozoites are released, and these 8 trophozoites are going to cause ulcer where? In the cecum and ascending colon. So what will be the problem here? There is formation of flask shaped ulcer. So here you can see cecum. So there is formation of flask shaped ulcer. Now see, this is the liver, right? This is the liver and this is the portal vein, right? Now these trophozoites are going to penetrate the capillaries, and after penetrating the capillaries, these trophozoites are going to enter into superior mesenteric vein, then portal vein, and then liver. So what will happen? Ultimately, the trophozoites reached where? In the liver. What is the name of organism? The name of organism is Entamoeba histolytica. So this Entamoeba histolytica starts doing histolysis. So what will happen? It is going to cause what? Can you see here? It will start histolysis, right? So you will notice at margins of the cavity there will be trophozoites which are eating away the liver tissue, doing the necrosis of hepatocytes, and in the center there is collection of reddish brown fluid because of necrosis of hepatocytes and WBCs, and this reddish brown fluid collection in the abscess cavity looks like anchovy sauce. So it is having anchovy sauce appearance. So these 8 trophozoites are going to cause flask shaped ulcers. Question is asked, what is the most common site of this flask shaped ulcers? It is cecum and ascending colon. What is the most common site of amoebic colitis? Cecum and ascending colon. And what is the most common site of amoeboma? Cecum and ascending colon. In Bailey, it's wrongly written that the most common site of amoebic colitis is sigmoid. It's wrong. So question, flask shaped ulcers. Second is amoebic colitis and amoeboma. Clear? For all these three, what is the most common site is the cecum and ascending colon. In majority of questions, both options are mentioned together. But suppose cecum and ascending colon are given separately in the question, then which one should be marked? If both are given separately, so cecum should be marked. Clear? Now, what kind of collection? There is reddish brown fluid collected, and that's known as anchovy sauce. So it is having what? Anchovy sauce appearance. Reddish brown fluid because of necrosis of WBCs and hepatocytes. So here you can see the color. So this is the color of anchovy sauce. So this is the abscess which is having anchovy sauce appearance. So in this case, what you have noticed that frank pus is not there, right? And if frank pus is not there, obviously fever is not the most common symptom, right? There are feeding trophozoites, and because of this, what happens? There is abdominal pain. There is fever, but fever is not the most common symptom. So in amoebic liver abscess, the most common symptom is abdominal pain. Here it is, abdominal pain. In pyogenic liver abscess, it was fever with chills and rigor. So what are the other symptoms here? So there is fever, there is anorexia and fatigue. Clear? And this question was asked in PGI Chandigarh that obstructive jaundice is common or rare. So here, jaundice is rare. In these patients, jaundice is rare. We discussed that there is destruction of hepatocytes, and in any situation whenever there is destruction of hepatocytes, what happens? The most common LFT abnormality is raised prothrombin time. So here, if we go for laboratory parameters, the most common LFT abnormality is raised PT. Clear? In Bailey is confirmed by serology. This is the point where most of the students are going to do the mistake. Be careful. This Entamoeba histolytica is not a bacteria, it's a parasite. And it's very difficult to culture the parasites. So here, our body forms antibodies against parasitic infestations and infections, and we are going to detect those antibodies by ELISA. So the questions related to investigations. First investigation, obviously, it's ultrasound. Diagnosis is highly suggested by ultrasound and CT, but diagnosis is confirmed by serology. So same thing will be applicable for hydatid cyst, because hydatid cyst is caused by Echinococcus granulosus, that is also a parasite. There also investigation of choice for diagnosis is what? Serology. So here the investigation of choice for diagnosis or diagnosis is confirmed by serology. Generally we perform what? ELISA. Okay, now coming to the management, since frank pus is not there, so we have to advise what? Antibiotics. And what is the drug of choice? It's high dose oral metronidazole. So treatment, what is the drug of choice? It's high dose oral metronidazole. Nowadays they are asking dose and duration also. So how much? We give double strength of metronidazole. So on an average it is 750 mg TDS for 10 to 14 days, right? See, symptomatic improvement occurs within 3 to 5 days, but radiological resolution takes 3 to 9 months, right? But symptomatic improvement occurs within 3 to 5 days. So after oral metronidazole, there is symptomatic improvement within 3 to 5 days. So this is the favorite question of AIIMS people. They used to ask this question, that generally in patients of amoebic liver abscess, we don't go for aspiration. So what are the indications of aspiration in amoebic liver abscess? So see, indications. of aspiration. Indications of aspiration in amoebic liver abscess. So there was symptomatic improvement within 3 to 5 days. So the indication is, first indication, no improvement. No improvement. Clear? Within 3 to 5 days. Second is high risk abscess. So what do you mean by high risk abscess? The cases in which there is high risk of rupture. So if the size of abscess is more than 5 centimeter, or left lobe abscess, left lobe is not properly supported, and that's why there is high risk of rupture. Okay, this question was asked many times in NIMS. See the language. So patient is having amoebic liver abscess, clear, and 3D dimensions are given. The dimensions are, it is 5.1 into 3 into 4.5 centimeter. So the abscess cavity dimensions are 5.1 into 3 into 4.5 centimeter. So is this an indication for aspiration? Yes. If 3D dimensions are given, any dimension more than 5 centimeter. So any single dimension more than 5 centimeter is an indication for aspiration. So here the size is more than 5 centimeter, 5.1. So this is an indication. Third, diagnostic uncertainty. Diagnostic uncertainty. Fourth, bacterial superinfection. Sometimes there is bacterial superinfection. And pregnancy. And pregnancy. Clear? Why pregnancy? Because in pregnancy high dose metronidazole is not safe, right? So this is how we manage the patients. Now we have to treat the carriers. What do you mean by carriers? See, there are certain patients who are asymptomatic carriers or cyst passers. So they themselves are not having any symptom, but they keep on passing quadrinuclear cyst. That's why you have noticed, especially in mess, we were in hostel, so you notice that some of our friends are going to develop typhoid, or some of our friends are going to develop diarrhea. Why? Because certain mess workers are harboring two dangerous organisms. One, they are harboring Entamoeba histolytica in the gut and Salmonella typhi in their gallbladder bile. So these mess workers are asymptomatic carriers or cyst passers, right? So we have to treat them also, and we have to give what? Intraluminal active agent for asymptomatic cyst passers. So what are the agents given? So treatment of carriers. So we give paromomycin, we give iodoquinol and diloxanide furoate. Clear? And how to remember? The mnemonic is PID. So PID is given for carriers: paromomycin, iodoquinol and diloxanide furoate. Third situation, certain patients are coming to our emergency with complication. Why? Because they are presented at later stages. See, this is the liver, and this patient is having large abscess. This is the diaphragm, and this is the heart. This is the pericardium. So see, whenever there is large abscess, it might rupture into the peritoneal cavity. So what are the complications? Rupture into peritoneal cavity, rupture into pleural cavity, and third situation, rupture into pericardial cavity. Clear? Question is asked, what is the most common complication? If you see Bailey, in Bailey it's written pleural cavity, and if you see Blumgart, which is the Bible of hepatobiliary surgery, in that it is mentioned that what? Peritoneal cavity. So we will follow Blumgart and we will go with what? Peritoneal cavity. Now if rupture is there into the peritoneal cavity, so what happens? The pus is going into peritoneal cavity, or the collection is going into peritoneal cavity. So we have to perform the laparotomy, we have to perform the lavage, and we have to insert a drain. If patient is having rupture into the pleural cavity, what is going to be sufficient? ICD insertion, intercostal drain insertion. And whenever this abscess cavity is going to rupture into pericardial cavity, it's an emergency. So first of all, we are going to insert a needle into pericardium and aspirate. If we are going to aspirate something with the help of needle, this is known as centesis. So what we are going to perform? Pericardiocentesis. And after that, we take the patient to OT and we perform pericardiotomy. So this is how we manage. So if rupture occurs in peritoneal cavity, we perform exploratory laparotomy plus peritoneal lavage, plus drain insertion. Clear? If rupture occurs into the pleural cavity, here we go for ICD insertion, intercostal drain insertion, and if it is into the pericardial cavity, we go for pericardiocentesis, followed by pericardiotomy. The next condition is hydatid cyst. Hydatid cyst is zoonosis, and it is seen in sheep grazing areas. What are the areas where this is more common? It is seen in Australia, New Zealand, East Africa and South America. Clear? So this is infection of animals mainly seen in sheep grazing areas. Now question is asked that what is the most common organism responsible for hydatid cyst? So the name of organism is Echinococcus granulosus. Apart from Echinococcus granulosus, there are 3 other species which are going to infect human beings. Second is Echinococcus multilocularis. Third is Echinococcus vogeli, and fourth is Echinococcus oligarthus. Clear? The question was asked in NEET. The question was that malignant hydatidosis is caused by which of the following organism, and these were the 4 options: granulosus, multilocularis, vogeli, oligarthus. Malignant hydatidosis means the hydatidosis which looks like malignancy in which multiple organs are involved. Clear? So the term is self-explanatory. In which condition multiple organs are involved simultaneously? Multilocularis. So this Echinococcus multilocularis, it is responsible for malignant hydatidosis. Clear? This is the question of NEET. Okay, last year this question was asked in AIIMS. Alveolar-like tumor in liver is caused by which of the following organism? So again, what? Echinococcus multilocularis. So the question was slow growing alveolar-like tumor in liver. So these are caused by what? Multilocularis. These are the 2 latest questions. Okay, so this is the organism. After that, what is the host? The definitive host is dog. What is the meaning of definitive host? The host in which sexual phase of cycle is occurring. Intermediate host is sheep. And what about human beings or man? Man is accidental. Be careful, it's accidental dead end intermediate host without human to human transmission. So the questions related to host. What is the definitive host? definitive host, it's dog. Intermediate host is the sheep, and the question is asked related to man. So man is accidental, dead end, accidental, dead end, intermediate host. Without human to human transmission. Without human to human transmission. Right? Here also, what is the route of infection? It's the fecal-oral. Okay. Now just try to understand what is the life cycle. Generally, this condition is seen in sheep grazing areas. There are slaughterhouses and sheep grazing areas. So sheep is going in those fields to graze the grasses. In slaughterhouses, the sheep is getting slaughtered, and sometimes their carcasses are thrown into the fields. Dogs are coming, they are going to eat those carcasses, and after that they are going to pass the fecal matter. Now see, if the dog is infected, in the fecal matter of dog, what? The cysts are being passed, or eggs of Echinococcus are passed, and these eggs are deposited on the plant leaves. So at the surface of plant leaves, these eggs are deposited, and sheep is going to graze those grass, and what happens? The cycle continues. If we are talking about human beings, what happens? Because of slow growing alveolar like tumor, in liver. So these are caused by what? Multilocularis. These are the two latest questions. Okay, so this is the organism. After that, what is the host? The definitive host is dog. What is the meaning of definitive host? The host in which sexual phase of cycle is occurring. Intermediate host is sheep. And what about human beings or man? Man is accidental. Be careful, it's accidental, dead end, intermediate host without human to human transmission. So the questions related to host. What is the definitive host? Definitive host, it's dog. Intermediate host is the sheep, and the question is asked related to man. So man is accidental, dead end, accidental, dead end, intermediate host. Without human to human transmission. Without human to human transmission. Right? Here also, what is the route of infection? It's the fecal-oral. Okay. Now just try to understand what is the life cycle. Generally, this condition is seen in sheep grazing areas. There are slaughterhouses and sheep grazing areas. So sheep is going in those fields to graze the grasses. In slaughterhouses, the sheep is getting slaughtered, and sometimes their carcasses are thrown into the fields. Dogs are coming, they are going to eat those carcasses, and after that they are going to pass the fecal matter. Now see, if the dog is infected, in the fecal matter of dog, what? The cysts are being passed, or eggs of Echinococcus are passed, and these eggs are deposited on the plant leaves. So at the surface of plant leaves, these eggs are deposited, and sheep is going to graze those grass, and what happens? The cycle continues. If we are talking about human beings, what happens? Because of, what is the route? Because of fecal-oral route, eggs are ingested. Clear? So eggs of Echinococcus are ingested, and these eggs of Echinococcus are converted into hexacanth larva. Hexacanth larva. Other name of this larva is oncosphere. Clear? So this oncosphere or hexacanth larva, it's there in duodenum. So see, this is duodenum and this is the liver, this is the portal vein, and this is what? Inferior vena cava. Now see, this is the larva. Clear? Larva is going to penetrate the capillaries, and after penetrating the capillaries, it reaches the portal vein, and from portal vein, it reaches liver. So what is the most common site of hydatid cyst? It's the liver. Certain larvas are going to bypass the liver, and these are going to enter into inferior vena cava. So from inferior vena cava, larva reaches right atrium, right ventricle, and then goes to the lungs. So what is the second most common site? It's the lungs. From lungs, it enters into left atrium and left ventricle, and from left ventricle, it is pumped into arterial circulation. It means other solid organs are also involved, like spleen, kidney, brain, and bone. So there are two routes. This hexacanth larva, it can either enter the portal vein, and if enters portal vein, what? There is involvement of liver. And if it enters IVC, so there is involvement of what? Lungs. There is involvement of spleen, kidney, brain, and bone. Clear? The question is asked, what is the most common site of hydatid cyst? It's the liver, followed by lungs, followed by spleen, followed by kidney, followed by brain, followed by bone. Now see the clinical features. Most patients are asymptomatic. What is the problem in the patients? These patients are having a cyst. Clear? But majority of patients are asymptomatic. If the patient is symptomatic, then what is the most common symptom? It's abdominal pain. In Bailey, it's wrongly written that it's a painful condition. No, in majority of cases, it's asymptomatic. What is the most common presentation? There is no symptom, but what? There is hepatomegaly. So the most common presentation is asymptomatic, palpable, intra-abdominal mass. So the most patients are asymptomatic. Most common presentation, and that is asymptomatic, palpable, intra-abdominal mass. And what's that? It's nothing. Hepatomegaly. It's the hepatomegaly. Simple. If the patient is symptomatic, in symptomatic patients, most common symptom is abdominal pain. So there is abdominal pain. There is abdominal discomfort. Why? Because of enlargement of liver, and there is dyspepsia. So abdominal pain, abdominal discomfort, and there is dyspepsia. Clear? What is the most common complication of hydatid cyst? Sometimes it ruptures into the bile duct, intrahepatic bile duct. So that is intrabiliary rupture. So the most common complication is intrabiliary rupture. Now the pattern of investigation is same here. First investigation done, ultrasound. Diagnosis is highly suggested by ultrasound or CT. Sometimes the image based question is asked on the basis of ultrasound or CT findings. So here you can see this is the gross appearance. You can see multiple cysts inside, and this is the ultrasound finding, and this is the CT finding, right? So what is the characteristic appearance on ultrasound? There is cyst within cyst appearance, and that is known as what? Rosette appearance. So on ultrasound, there is cyst within cyst appearance, and that's known as what? Rosette appearance. Clear? And on CT, there is ring-like calcification. This is the characteristic finding, ring-like calcification, and this was asked in NEET. So here you can see how this ring-like calcification looks like. So this is the ring-like calcification. So ring-like calcification on CT, characteristic feature of what? Hydatid cyst. But since it's a parasitic condition, we discussed that the investigation of choice or diagnosis is confirmed by serology. So in patients of hydatid cyst, investigation of choice for diagnosis is the serology, right? So what are those investigations which are performed in serology, and the investigations having more than 95% of sensitivity and specificity? So the three investigations which are done here, one is ELISA, second is ARC5, and the third is immunoblot. Clear? So it is ELISA, ARC5 and immunoblot, and all these three are having more than 95% of sensitivity and specificity. One question is asked related to Cazzoni's test. What is the biggest problem of Cazzoni's test? That its sensitivity is 55 to 60% only. And the second, since there is intradermal injection of sterile hydrated fluid, there is risk of anaphylaxis. So Cazzoni's test is obsolete. Cazzoni's test, it's obsolete. Why? Because the sensitivity, it is very low, 55 to 60%. This was asked in NEET. They asked the percentage directly, and there is risk of anaphylaxis. Clear? So there is risk of anaphylaxis. That's why this test is obsolete. So the moment diagnosis is done, what we have to start the drug, and the drug is used for perioperative chemoprophylaxis. So what is the drug of choice for perioperative chemoprophylaxis? It's the albendazole, and the alternative of albendazole is mebendazole. So medical management, drug of choice for perioperative chemoprophylaxis. Perioperative chemoprophylaxis. Clear? And this is albendazole, and the alternative of albendazole is what? Mebendazole. Is the mebendazole, right? Now see, this albendazole is colicidal, and it is going to shrink the size of cyst. That's why it is given for perioperative chemoprophylaxis. So the advantage is that this is colicidal and it shrinks the size of cyst. Now suppose there is a rare situation in which there is an elderly patient who is having lots of comorbidities. Simultaneously that person is having what? Hidatidosis or hydatid cyst. So in that case surgery is a bit difficult, dangerous. So in that case we just go for what? Albendazole. Clear? So for perioperative chemoprophylaxis we give albendazole. Nowadays PAIR is most preferred technique, is a surgical intervention. So PAIR is most preferred technique for anatomical and surgical appropriate lesion. What is the meaning? If the condition permits PAIR, if the lesion is anatomically and surgically appropriate, PAIR is most preferred. So what are the surgical interventions performed? Surgical interventions. First is PAIR. Okay, so PAIR is most preferred. You have to remember this. It is most preferred for anatomically and surgically appropriate lesions. Okay, what is the full form of PAIR? P means puncture, so we perform puncture. Aspiration, see, it's not percutaneous because PAIR can be performed by percutaneous approach also, by open approach also. So P is not percutaneous, P is puncture. It is aspiration. I means instillation of scolicidal agents, and R means reaspiration, right? So this is puncture, aspiration of contents, instillation of scolicidal agents, and reaspiration. Now see how we perform it. This is liver. Clear? And this is the cyst. Inside cyst there is cyst content, scolex, Clear? So what you do, first you puncture the cyst. After puncturing the cyst, you aspirate the content so that there is some space created inside the cyst cavity, and after that you instill the scolicidal agent. When you are going to instill the scolicidal agent, it is going to kill the scolex. We wait for some time and then we re-aspirate it. So we have to instill the scolicidal agent. So what are the scolicidal agents used? So the scolicidal agents, most commonly used scolicidal agent is hypertonic saline. So this is hypertonic saline. The hypertonic saline used for IV infusion is 3%, but the hypertonic saline used as scolicidal agent is 20%. So see, it's not 3%, it's 20. And this is the most commonly used. Clear? What are the other scolicidal agents used? Second is 0.5% cetrimide with 0.05% chlorhexidine. We use 10% povidone iodine, 10% povidone iodine, and we use absolute alcohol. You have to remember the percentages also. Absolute alcohol. See, previously formalin and silver nitrate were also used, but nowadays because of toxicity, formalin and silver nitrate is not used. So in majority of cases we have to perform the pair, but there are certain situations where you cannot perform the pair. So what are the contraindications of pair? Contraindications of pair. Imagine a situation, liver, and here is the cyst. So what? It's peripherally located cyst, and the moment you are going to puncture the cyst, cyst will rupture. So what is first contraindication? Peripherally located cyst. Is the peripherally located. Second, suppose the cyst is in close relation with some vessel where there is no direct access possible. So what? Inaccessible cyst. Inaccessible cyst. Third situation, imagine this is the cyst and the cyst is having what? Multi-septations. So the cyst is having multiple septations, so this is multiloculated cyst. If you are going to perform the pair in multiloculated cyst, what? At one point of time you are going to perform pair in one loculi only, and at the end of procedure you are not 100% sure that whether all the loculi has been treated or not, so there is high risk of recurrence. So third is multiloculated cyst. Cystobiliary communication. Why? If there is cystobiliary communication and if you are going to inject the scolicidal agent, because of communication the scolicidal agent enters into the bile duct and it can cause cholangitis. Next is cyst in lungs and brain. Cyst in lungs and brain. Why? Because it's dangerous to perform pair in lungs and brain. And second problem, in lungs and brain there is no pericyst. What is pericyst? See, there is endocyst, then there is ectocyst, and there is pericyst. Clear? See, this endocyst and ectocyst. Endocyst and ectocyst, these are the parts of parasite, right? But this pericyst, this is the part of host. How the cyst is going to get its nutrition? The cyst gets its nutrition via this pericyst, via diffusion, right? So by diffusion cyst gets its nutrition via this pericyst. So in lungs and brain there is no pericyst. What is the another condition in which pair is contraindicated? Yes, calcified cyst. Why calcified cyst? Now see, if there is calcification, we discussed ring-like calcification. So if there is calcification, now cyst is not getting its nutrition. So cyst is already dead. So calcified cyst, it's a contraindication because it's a dead cyst, right? So if pair is contraindicated, we can go for evacuation of cyst content and obliteration of cyst cavity. How we do it? See, this is liver and this is the cyst. This is the cyst content, okay? So what you do, you divide one wall, and after dividing one wall, what you do, you evacuate the cyst content. After evacuating the cyst content, you are going to put omentum inside, and after that you are going to obliterate the cavity by fixing the omentum. You fix the omentum inside the cavity, so this is known as omentopexy or omentoplasty. So what is the name of this procedure? This is cyst evacuation with omentopexy. Okay. Sometimes if you don't want to put omentum inside, what you do, you can obliterate the cyst cavity with the help of sutures. And if you are obliterating the cyst cavity with the help of sutures, this is known as capitonage, and there is another technique known as introflexion. So this obliteration can also be done by, this was asked in Maharashtra once, capitonage or introflexion. So after cyst evacuation and omentopexy, how the condition looks like? This is how it looks like. So see, the omentum, it has been inserted into the cyst cavity. After that, it is being fixed. The third treatment option is pericystectomy, and this pericystectomy is the most effective treatment. Pericystectomy is the most effective treatment. Clear? The questions where the students are going to make the mistake. See, the question is asked, what is most preferred for anatomically and surgically appropriate lesions? Pair is most preferred, and what is most effective? It's the pericystectomy. Why? Because the rate of recurrence is very low after pericystectomy. So what is the meaning of pericystectomy? We are going to excise the cyst outside of pericyst. So here you can see that this is the cyst, and I'm going to excise this cyst just outside of pericyst. So this is pericystectomy. This is the most effective treatment. Fourth treatment option is hepatic resection. Hepatic resection. And hepatic resection is most radical treatment. Suppose one segment is containing the cyst, you are going to excise that whole segment. So this is most radical treatment. Clear? So these are the surgical treatment options for hydatid cyst. In radiology as well as in surgery, there is a classification system which is frequently asked related to ultrasound findings of hydatid cyst, and that's known as Gharbee's classification. So Gharbee's classification it is based on ultrasound. See, what is type 1? In type 1, there is simple fluid collection, right? What is type 2? In type 2, there is floating membrane or undulating membrane. So what happens? There is floating membrane or undulating membrane. So this floating membrane or undulating membrane, it is also known as water lily sign, also known as water snake sign. So what are the other names? Water lily or water snake sign. Clear? This is the question which is frequently asked. Sometimes they ask direct question that water lily sign is seen in which condition, and sometimes they ask image based question. So see how it looks like. This is the water lily sign, and this image based question was asked in FMG August 2020 exam, and it was asked previously also in many other exams. So this is type 2. Type 1 is simple fluid collection. Okay. What happens in type 3? In type 3, yes, the cyst becomes multiseptated or multiloculated. So if this cyst becomes multiseptated or multiloculated, it is also known as honeycombing. So this is multiseptated or multiloculated. It is also known as honeycombing. Honeycombing. See, there is another question which is asked. Honeycombing is seen in hydrated cyst, but honeycomb liver, it is seen in actinomycosis. So, if the question is asked, honeycomb liver, right? This honeycomb liver, it is seen in actinomycosis. So, this is type 3. What happens after that? In type 4, there are solid areas as well as cystic areas. So, very similar to type 3. But what happens? There are solid areas as well as there are cystic areas. So any cyst in which there is presence of both solid areas and cystic areas, that cyst is known as complex and heterogeneous. So see this, type 4 is, it's complex heterogeneous mass. Complex heterogeneous mass. Clear? And what happens in type 5? In type 5, the cyst is calcified. So it is very easy to remember. How? This classification tells you about beginning of the cyst till its end. So in the beginning there is simple fluid collection only. Then there is floating membrane or undulating membrane known as water lily sign or water snake sign. Then it becomes multiseptated or multiloculated. Then there is appearance of solid areas also known as complex heterogeneous mass. And type 5, what? It is calcified cyst. And we discussed calcified cyst means dead cyst. So this is hydrated cyst. Now we discuss 3 situations: amoebic liver abscess, pyogenic liver abscess and hydrated cyst. And there are similarities in these 3. In amoebic liver abscess, pyogenic liver abscess and hydrated cyst, what are the similarities? So pyogenic liver abscess, amoebic liver abscess and hydrated cyst. First, in majority of these cases, what? Most of the patients have single cavity. So they have single cavity, and which lobe is most commonly involved? Right lobe of liver. And the X-ray changes are similar. So what are the chest X-ray changes similar? There is raised right dome of diaphragm, there is reactive pleural effusion and atelectasis or collapse of right lung. So chest X-ray changes are also similar. Findings: raised right dome of diaphragm, there is reactive pleural effusion, and there is atelectasis or collapse of right lung. Atelectasis of right lung. Clear? So these are the similarities between amoebic liver abscess, pyogenic liver abscess and hydrated cyst.